I'd like to express my thankfulness to all of you who are invited to this webinar. And I'm Tracy Xia from Ezisurg Medical, and I'd like to firstly give a brief introduction to our company. Then let's introduce welcome the speakers for this webinar. So Ezisurg Medical was founded in November 2011 and specializes in the development and commercialization of high-end minimally invasive products targeting diseases associated with general, bariatric, thoracic, and colorectal procedures. Ezisurg Medical is committed to providing comprehensive and integrated solutions to the global market. Every day, our more than 500 employees' efforts are focused on the mission of providing premium and affordable MIS products to hospitals, surgeons, and their patients. This commitment is rooted in the development of best-in-class devices that are rooted in strong clinical and health economic evidence that supports the entire patient care continuum. In this way, Ezisurg Medical is dedicated to establishing our reputation as an innovative, market-leading, best-in-class device manufacturer. In 10 years, we intend to take a leadership role as a provider of MIS devices in China and to become a competitive player by exerting significant influence on the global market. And we'd like to introduce you a little bit about our webinar series as well. Ezisurg has been dedicating to overall excellence of clinical performance through both theoretical and empirical contributions, and we hope we could jointly promote the improvement of scientific research and medical standards in the field of international obesity and bariatric surgery through our webinars. For this particular webinar, we are very honored to be able to invite the following experts who have achieved excellence in the bariatric field to be our moderator and speakers. And our moderator, Dr. Lefan Smalazadeh from the USA, Dr. Mohammed Rashdan from Jordan, Dr. Percy Brand from Chile, Dr. Mark Vertrian from Belgium, and Dr. Harris Kwahya from United Kingdom. We'd like to express our thankfulness to all of our invited guests, and we wish you an enjoyable and intriguing journey. Thank you so much.
Thank you very much for your kind introduction, and I want particularly express my gratitude to Ezisurg Medical for organizing series of an extremely interesting and useful webinars about important topics in minimally invasive and bariatric surgery. I'm really honored to be invited as a moderator on today's webinar. And I'm pleased to introduce our dear speakers, world-renowned experts in the field of bariatric surgery and minimally invasive surgery. And I apologize in advance if my spelling of your names, dear speakers, is not precise. On the other hand, I understand that pronouncing my last name might be even more challenging. So we have 4 speakers today. Our speakers are Dr. Mohammed Rashdan, Assistant Professor of Minimally Invasive Surgery, Faculty of Medicine, the University of Jordan, Dr. Percy Brandt, New Technologies Department of Chilean Bariatric Surgical Society, Dr. Mark Ventrian, Chief General and Abdominal Surgeon, Clinics de Europe, Brussels, Belgium, and last but not least, Dr. Harris Kwahya, Consultant Upper GI and Bariatric Surgeon, Chelsea and Westminster Hospital and Imperial College, London, United Kingdom. So let's turn our attention to agenda of today's webinar, and the first topic will be presenting Dr. Mohammed Rashdan, and the topic will be about what the patient needs to know before choosing the type of surgery, proper counseling. You're welcome to present your topic, Dr. Rashdan. Connection with Dr. Rashdan. As long as we have some technical issues with Dr. Rashdan, We can move on and come back to this topic later, and we can discuss the next topic, gastric sleeve, pros and cons, with Dr. Percy Brante. You're welcome to present your topic, Dr. Brante.
Well, thanks so much for the invitation. It's a pleasure to be with such experts. And let me show you my presentation. Please let me know if you have it.
We do have it. Thank you.
Okay, perfect. Perfect. So the topic I was asked for to talk about is something that's very usual nowadays. As a matter of fact, is probably the most frequent surgical intervention for obesity. That is gastric sleeve nowadays. Just to start, this is a publication from year 2018. And this is basically to show that gastric sleeve is being taken place for over the 14 years. And nowadays is the most frequent procedure for obesity, taking care of 55 and something % of the total surgeries performed around the world. Those are the data presented by IFSO from different chapters all around the world. And as you can see, the second place is gastric, Roux-en-Y gastric bypass, sorry, taken care of 29 or something % of the total procedure. And very, very far behind come all the rest of the procedures, like one anastomosis gastric bypass. That's been some technique that's been taking important numbers lately, but far away from that. And then we have the rest of surgeries, for calling them somehow. The sleeve gastrectomy, making some history about it, it started or was described in the 1990s as a procedure to be part of a two-stage procedure in super obese patients with BMI over 60. And the intention was to take them down to a safer weight to perform a biliopancreatic diversion. Afterwards, in 1999, it was described the first laparoscopic sleeve gastrectomy. And since its advantages, for saying it somehow, by the year 2008, there was a publication that showed the indications for sleeve gastrectomy that started from then on, I'm sorry. The weight loss in these techniques usually takes its peak by 18 or 24 months. And there are some alterations in several hormones like ghrelin, GIP, GLP, PYY, as it's described in Roux-en-Y gastric bypass. The pros of these techniques is the fact that you can achieve an excellent reduction in excess weight loss, around 60%. This weight loss is durable. There are a lot of improvements in medical illnesses, so has little differences with results with gastric bypass. This resolution, as I told you, has not much to envy the results of gastric bypass. As a difference with gastric bypass, the incidence of nutrition deficiency are way lower. Technically, it's an easier procedure. It lacks of 2 anastomoses compared with the gastric bypass, and compared also with the gastric bypass, the gastrojejunostomy, that is the most critical step of this surgery in mentioning complications. You can avoid that. It has objectively less morbidity than gastric bypass, and the mortality is described from 0 to 1.2% in expert centers or excellent centers. The complications might be classified in early and late. The early, of course, the most important of them is the hemorrhage, described in 1 up to 6%. And there's no significant difference between intra or extra luminal bleeding. And in this, regarding this matter, this topic, the use of buttressings have shown an important decrease in the presentation of this complication. And the other early complication are the leaks that could be classified as acute or chronic. Sorry, and it depends on if they present before the 5th day after surgery, or then after probably 10 or 15 days after, and the lasting of its resolution. The late complications are really, I mean, stricture, that's the most mentioned one. And this stricture has very much to do with technical issues, and is the fact on probably performing the second cut of the stomach so near to the angular region, or too close to the bougie in case of using a very thin boogie. That's why the description of the technique considers usually the use of a bougie of 32 up to 36 French, no less than that. And the other late complication that has very not so objective evidence is the presentation of GERD. And what we've seen related with that is, more than the appearance of primary GERD, is the fact of persistence of GERD in patients with a bad selection for the technique. I mean, patients that before surgery had a clinical history of GERD, or patients with endoscopic findings of B esophagitis or higher than that, that were submitted to this kind of surgery with the wrong indication. That's at least what in our experience have seen. The complications of sleeve gastrectomy, of course, as I told you before, are acute or chronic. But the cons of this surgery are the presentation of some syndromes or some clinical behaviors that are not so often mentioned. And the fact is that there is a low incidence of dumping. but there is some dumping with the sleeve gastrectomy, and reports have shown up to 26% of it. And there's not much to do related with this. There is some evidence that with Roux-en-Y gastric bypass, the damping has to do with the length of the biliary limb. But in this situation, we have not much to do, and it supposedly has to do with all the alterations of secretion of incretins and GLP-1 and PYY and all the hormones that has to do with the modification of the intestinal tract. Another very low incidence complications, but it has to be taken in mind, is the presentation of the Wernicke-Korsakoff syndrome. That's secondary to the deficiency of thiamine and B vitamin, and that accounts for 1% of the patients, usually more in young patients, and the presentations usually takes place after 1 month after surgery, and sometimes it presents just with a vomiting syndrome without any apparent cause. And every time you start to ask some things and to examine the patients and to look for some neurological abnormalities with the assessment of a neurologist, you get to realize that it's a deficiency in thiamine. On the other hand, the other con is the presentation of a 5.8% of 30-day complications. That, of course, it's a rate that may vary from center to center, but that objectively is lower and significantly lower than a gastric bypass that accounts for 8%. So what we are looking with a sleeve gastrectomy is a pure restrictive procedure, as you can see on your left part of the screen, that with the time has shown to have definitely interaction with the secretion of gastrointestinal hormones that also account for the fact of excess weight loss. Right now, everyone agreeing that it doesn't have to do exclusively with a restrictive procedure. Then you have the fact of the X-ray control with the restriction. On the right hand of the screen, you can see what is expected to be removed. At least 4/5 of the complete stomach. In these short videos, just some, it seems that it's not running. Do you have any vision of it?
No.
No, I don't think so. No, sorry, they're not running. Sorry about that. And just 1 second, sorry. And what we are trying to avoid in these techniques is the fact of leaving a large fundus, like you can see in the left side of the screen, missing a hiatal hernia with an important remnant of fundus, or a large complete gastric sleeve, as you can see on the right side of the screen. Usually what we are trying to achieve is is a gastric sleeve with a total capacity of about 200 cc's. So finally, the conclusions of this technique, we might say that its efficacy has been proven from long time up to now. It's an easy surgery to be performed. It has less complications than the gold standard, that's Roux-en-Y gastric bypass. And the results in terms of weight loss and improvement of comorbidities are quite similar. So thanks so much.
Thank you very much, Dr. Brante, for your interesting presentation. I would like to ask you a few questions.
Sure.
So, as you have mentioned, laparoscopic sleeve gastrectomy is like easier procedure. It has acceptable outcomes and it's more physiological. And I want to hear your opinion if there are any studies comparing short-term and long-term outcomes like morbidity, mortality, estimated body weight loss between these two most commonly performed procedures, laparoscopic sleeve gastrectomy and gastric bypass.
Yes, there are several studies about that. And the conclusions are that gastric bypass has a slight higher higher numbers in terms of excess weight loss in time. You might achieve up to an 80% of excess weight loss with gastric bypass, compared probably with a 60 to 70% of gastric sleeve. And with a couple of years higher in lasting of this excess weight loss.
Okay, thank you. Sorry.
I'm sorry. And the last thing, and the comparison between morbidity and mortality are demonstrated and published in more than one study that gastric sleeve has lower 30-day morbidity and mortality, and also long-term morbidity and mortality than gastric bypass. And if you compare both techniques on the long term, you can see that in both there's no statistically significant difference between the correction and improvement of comorbidities.
Thank you very much. And I have a last question. Dr. Brante, are there any absolute contraindications to laparoscopic sleeve gastrectomy? Let's say, are there any patients' condition when you never go for sleeve gastrectomy?
Well, I would say that probably the most important fact to be studied and to be very precise in establishing it is the fact of gastroesophageal reflux. We know that gastric sleeve in time has shown us that it's a very pro-GERD technique. So every time you face a patient that has clinically an important reflux, or you have a patient that has a condition with an endoscopy that's showing you an important type of reflux, I mean like grade B or higher, that's a patient that for sure will probably lose weight and will work perfectly for the excess weight loss, but it will do very bad in terms of reflux, and it will increase, and finally will end up converted into a Roux-en-Y gastric bypass.
Thank you very much, dear Dr. Brante, for your presentations, for your definitive answers. Dear Tracy, do we have a connection with Dr. Mohammed Rashdan?
Hello? Yeah, I'm Dr. Rashdan.
Hello, Dr. Rashdan.
Hi, how are you? I'm sorry for this problem. I found a way to fix it. Probably my laptop mic is not working. So I already logged in with my phone. So I'll use my phone for the audio and share my slides on the laptop.
Thank you very much, Dr. Rashdan. And Dr. Rashdan will be presenting the study and the topic about what the patient needs to know before choosing the type of surgery, proper counseling. Feel free, Dr. Rashdan, and present your topic.
Okay, thank you very much, everyone. Thank you for Ezisurg for having this great honor, this chance to meet these panel of experts, really pioneers in the bariatric surgeries. I hope my sharing my ideas will be informative, will be helpful, beneficial for everyone to learn from each other. Let me introduce myself. I practice here in Jordan at the University of Jordan, Jordan University Hospital. I did my bariatric fellowship in 2015 at the University of Illinois at Chicago. And you know, a minimally invasive procedure. Again, Dr. Branty, thank you for your nice presentation. Actually, it's gonna be interacting with mine. Hopefully, will enforce data for the for participants. As you know, all health problems we deal with. One of them is the obesity. Obesity, we deal with it as a disease. It's not a cosmesis anymore. We deal with any other kinds of illnesses. We deal with multiple modalities of treatment, from least invasive to the most aggressive procedures, from lifestyle modification, medical therapy, and the surgical options. And you know, nowadays it's well proven that surgery is the most effective, the most sustainable, provides the most sustainable results in terms of weight loss for these severe obesity patients and the morbidly obese patients. So when you have your patient coming to your clinic seeking your help, asking for what are the options, probably all of us know starts from proper history, physical examination, doing the proper workup, the lab tests, and all the things need to optimize your patient to go for surgery. We look for answers. We look for answers for our questions, for the patient's questions, and we end up having the common question, which is which kind of surgery we go for. Honestly, for me, I do most of my practice is in the sleeve gastrectomy and the Roux-en-Y gastric bypass, but I still believe that there is no ideal bariatric procedure. There is what we call tailored management for each patient. We need to sit with the patient, make a common decision. I mean, it's not an easy process. It's kind of multifactorial, a little bit complex sometimes in specific cases. But I mean, you can end up having a short list of the most, let's say, suitable procedure for your patient. You can offer plan A, plan B, and you can give your decision, or you can give your advice. But sometimes the patient has a major role in this process. We discuss to our patients the different options, from the least invasive to the most aggressive, most effective, of course, with increased risk of complications. This is, as we said, we discuss many things, we answer many questions. I'm not gonna go through every single thing we discuss with the patients, but I mean, I'll stress the points that affect the decision making, which kind of procedure we will go. So actually, in our society, in our practice, sometimes you have a patient who's already predetermined, have the answers there. I mean, probably because many patients nowadays, they are well, I mean, educated. They go and read. They have exposure to the what the literature says, and they tell you, I've read about these options. I think for me, I'm having this and having this. I would like to go undergo a sleeve gastrectomy or ONY, or sometimes they are suggesting other options. Actually, sometimes this is beneficial. It makes, I mean, it gives you, I mean, patient is already educated, so you don't need to stress all the points, but sometimes it plays in a negative way. I mean, nowadays, social media, the relatives, previous exposure, previous experience with relatives, with friends, sometimes can affect the patient. If the patient come probably because he's having, I've seen a complication or let's say not a very good quality of life for his patient, for his relative or friend undergone a specific procedure, so he doesn't want this procedure despite being the best for him. So apart from this, we discuss, I mean, the outcomes of procedure, as Dr. Branti said, regarding the sleeve and the bypass, they are comparable. They have comparable results with a slight edge of the bypass over the sleeve gastrectomy in terms of excess weight loss, a little bit more sustainable weight loss, I mean, faster weight loss. But at the end, many meta-analyses, especially the Scandinavian studies, who I mean, provided in tens of thousands of patients, they came up with this result that really the sleeve and the bypass, they have comparable results in terms of excess weight loss. So I don't think this is I mean, a major factor to I mean, decide to go for sleeve or bypass. We go through the morbidities of the patients and we tell them in numbers the effect of the sleeve, the effect of bypass on morbidities. Specifically, I mean, what we used to call metabolic syndrome, the diabetes, the dyslipidemia, etc. The effect of other comorbidities, like the as Dr. Branti stressed on the gastroesophageal reflux disease. We don't prefer to go for sleeve if there is a gastroesophageal reflux disease, but as all I mean, or many authors, they don't consider it an absolute contraindication. It's a little, I think, I prefer to say it is a relative contraindication for sleeve gastrectomy. What really I want to hear from others, the quality of life studies in these in large populations. I don't think there is a decisive answer for this. I mean, probably they have comparable results, but if someone has a decisive answer, if the quality of life differs between these sleeve and bypass, or prefers one over other, I would be happy or glad to hear from him. Regarding vitamins, I want to stress on this point, and probably we'll discuss in the next few slides. All thinking, we used to think that the sleeve gastrectomy does not change the route of the food, does not cause malabsorption, and does not cause micronutrient deficiency. Nowadays, I mean, a lot changed. I mean, the new guidelines, they support, there is evidence supporting that it is recommended to give these patients either the sleeve or bypass the same requirements for the micronutrients. I'm talking about the ASMBS guidelines for replacement of micronutrients after these surgeries. Of course, this is another thing to consider is the pre-op evaluation. Again, obesity is a disease and is associated with vitamin deficiency. It's a state of, let's say, malnutrition. So things also we discuss with our patients, we stress on eating behaviors. We used to think that volume versus sweet eaters makes a good, decision-making factor. If your patient is telling you I'm taking large amounts, large meals, binge eating, versus someone else who doesn't think that he's taking large amounts, but he thinks most of his diet is carbs and milkshakes and energy drinks. So probably will go for the sleeve in volume eaters, as it stretches the volume, it will work well with them, but with bypass in sweet eaters, because we'll have the desirable side effect or the desirable complication of bypass, which is the dumping syndrome. In these patients, if they eat or drink large carb intake, they will get the dumping, and they will learn from their practice that if they do it again, they will suffer. So it's kind of a desirable side effect from this surgery. Smoking is a very important thing to consider. In our society in Jordan, we really suffer from this problem because we probably Jordan one of the highest numbers in terms of smoking among populations in the world. So we do make a big consideration for this factor. We tell our patients, first of all, smoking increased risk of complications. We always recommend at least 4 weeks of smoking cessation before surgery, preferably 8 weeks before surgery. And even if you do that, there's still increased risk of complication postoperatively. One more thing is the anastomotic ulcer. We still, don't advise doing a bypass for a patient who's not willing to quit smoking. But some reports, something in literature says that really the anastomotic ulcer is a technical problem. It's not purely due to exposure to smoking or other factors. And probably Dr. Brandt talked about some contraindications for surgery. So we all also discuss these factors in our. I'm not gonna go through repetitive informations. We explain to our patients the difference between different kinds of surgery, the expected outcome, excess weight loss, expected morbidity, mortality, and have an idea about the outcome. As we said, most of our patients, they go either laparoscopic gastric bypass or the sleeve gastrectomy. We prefer to go with a higher, like in 50s BMIs for a bypass rather than sleeve gastrectomy because of the slight edge of weight loss. But actually, what I've learned from my fellowship days that if you have a super obese patient, BMI is more than 60, we don't prefer to go for bypass. It's technically very difficult, first of all. Then we prefer to go for a 2-stage procedure. So it's kind of here, we don't give the patient the choice. Let's say if he is like 65 BMI and he had a bypass and he lost like 70-75% of excess weight loss, he will end up having a BMI of the 40s the most. So he will still be a morbidly obese patient. So we prefer to go for a sleeve gastrectomy, having the weight loss, and then offer a second option, either a bypass or a biliopancreatic diversion or another kind of the procedure, bypass procedures. Again, we'll not repeat what already said. In terms of sleeve gastrectomy is as effective as the bypass. Another thing is the malabsorption. As we said, normal malabsorption, that was the old thinking. I think by a sleeve needs to be replaced, I mean, with micronutrients. Again, this is, I mean, Dr. Brandt talked about the technical part of the sleeve gastrectomy, which is very important, especially in areas or countries where you do large numbers, and they have not only the bariatric surgeons performing the procedures. I mean, it's technically easier. Any general surgeon can do it technically, probably not I mean, in the best way, but technically, I'm sorry, hypothetically can do it, but not all surgeons can do the laparoscopic gastric bypass, and we know is laparoscopy the standard of care, so they cannot go for open. So sometimes they affect the decision of the patient. They say make everything is good for the sleeve and make it the best option, because I mean simply cannot do the Roux-en-Y gastric bypass laparoscopically. And I think if you cannot do it, I mean anyone who cannot do it laparoscopic gastric bypass, at least he should inform the patient about this option. And if the patient opted for this option, just I mean call someone else, call help and from bariatric surgeon, someone experienced to do the Roux-en-Y, or send the patient to your colleague to do the Roux-en-Y gastric bypass. About the nutrients, so vitamins and mineral deficiencies associated with obesity even before having surgery. This is proved literature. As we said, vitamin, I mean, is considered a form of malnutrition. And many deficiencies has been seen before, like iron, B vitamins, D, and different kind of deficiencies. After surgery, what happens? We have many problems. There is decreased intake, there is the dumping, there is the food intolerance, the repetitive vomiting, and there is the malabsorption, which is the mechanism of action from the procedure. So we need to stress this point for our patients, both the sleeve and the bypass. You can see the recent guidelines, recommendations from the ASMBS. Actually, I don't think and don't see difference in recommendation between the sleeve and the Roux-en-Y gastric bypass in the preventive recommendations, and also in the corrective or therapeutic recommendation from the regarding smoking. As we said, tobacco smoking should be 1 year before procedure can increase the old morbidity and major complications. Smoking cessation at our institution and most good institutions, they recommend at least 4 to 8 weeks of smoking cessation before surgery. Preferably if they quit smoking, this is the best thing. But I mean, at least we ask for 4 to 8 weeks before procedure. Let me share with you this cross-sectional study we did at our hospital, and we looked and asked ourselves, do we do proper counseling, and what about the counseling? Did it affect the decision of the patient? So we asked multiple questions. We asked the patients what been asked or what been explained to you before surgery. Did they talk to you about the outcome of sleeve regarding reflux, regarding weight loss, regarding complication, etc.? Also, the same thing for bypass. Did they explain the outcome? Did they explain the complication, the effect of each surgery on the reflux, the effect of each surgery on the comorbidities like the bypass, like the diabetes, like the dyslipidemia? And actually, we found most of our patients properly counseled, but at the end, it did not affect the patient choice. I mean, what we consider after reviewing our patient suitable more for sleeve gastrectomy or bypass, I mean, significantly did not affect their decision. Probably because of what I spoke about in the beginning of this talk, that many factors affect the decision, especially the social, the factors, the reading of the previous experience affected their patient decision. Thank you very much. I invite you to come and visit us in Jordan and have a nice time. Probably will be happy to host you.
Thank you very much, Dr. Rashtan, for your outstanding presentation. It seems obvious that discussion with the patient and their families about risk factors, about possible intraoperative and postoperative complications helps building trust and facilitates a proper decision-making process regarding most suitable bariatric procedure for particular patient. What is the average time? And I know sometimes it's challenging and it's difficult in particular cases. Average time you spend with the patient when discussing about procedures, about pros and cons, and trying to choose a most appropriate bariatric procedure for the patient.
So what we do in our practice actually, first, the patient come to our service first. I mean, what we used to do in Chicago, I mean, United States, that the patient comes referred from the metabolic doctor. You know, this is not a one-man show. It should be a multidisciplinary team from the metabolic doctor, the dietitian, the surgeon, and other specialties involved in this work. But in our practice, patients come to our clinic as first visit. So we sit with them, they discuss, we take proper history and physical examination, history of the obesity and the comorbidities. We think of the major things we must do to optimize our patient before surgery, and then ask the proper workup and the consultations before doing surgery with the cardiologist or metabolic doctor, the psychiatrist and dietitian, etc. So it takes around, I would say, 20-30 minutes in the first visit discussion with the patient. But each time the patient come to the clinic, I mean, finishing the workup, I mean, we sometimes give them the time to choose. We don't, write down the final decision until we book the patient for surgery. And even that, we tell our patients, when you have until you are called to surgery to change your mind. But I mean, before going down to OR, to the holding area, just let us know to make the concept proper for you. But I mean, it's always time for them to ask questions, and we are happy to answer.
Thank you very much again, Dr. Rashtan. Thank you very much for your interesting presentation. Let's move on, and I would like to invite our next speaker, Dr. Marc Vertruyen, who will be presenting the topic about the respective indications of the sleeve and the bypass.
Yes. So I will share my. Okay. Okay, can you see my slides?
Yeah, sure.
Yes, okay. So first of all, I wanted to thank you for inviting me to this very interesting webinar about sleeve and gastric bypasses. My presentation will be today with the respective indication of sleeve and bypass. These interventions are become very frequent and are in high demand by our patients. And these two operations are now well codified, and we have very efficient stapling equipment to reduce our complication rates as much as possible. But the best of surgeries with a bad indication will result in a failure and a disappointing of the patient. So we currently have enough experience now to better establish our indications. I therefore propose to present you the surgical indications that we use in our multidisciplinary team. So the common indications for both surgery, sleeve and gastric bypass, are indeed morbid obesity in a patient over 80 years of age. The BMI will be over than 40. We also accept the BMI greater than 35 with a risk factor such as sleep apnea syndrome, diabetes, or difficulty to control hypertension, and also a revisional surgery for insufficient weight loss. Now, everybody will be agree when I say that it's important to remember some basic concepts, that obesity is the consequence of a diet behavior problem, that sleeve or gastric bypass do not burn any additional calories, and surgery alone is not the solution. So it's important also to note that in our experience, the contraindications for one surgery become indications for the other surgery. So the contraindications for a sleeve becomes the best arguments to propose a gastric bypass to our patients. Sorry, I have a little bit too. Sorry, I will do it too fast. So the presence of a gastroesophageal reflux disease, the presence of esophagitis B and C, a Barrett metaplasia, patients who are sweet eaters, of patients with snacking habits, unstable diabetes, or a BMI higher than 45 in our team are formal contraindication to propose a sleeve gastrectomy. Because we think that it will aggravate a pre-existing GERD and esophagitis. It can accelerate the occurrence of esophageal cancer. And also it will give bad results in case of sweet eaters, of patients with snacking habits. So in all these cases, well, we propose a gastric bypass. Now there are special cases, and I want to discuss with you with these cases. The first special case is the redo surgery. Well, in the case of insufficient results, we can just evolve from, for example, from a ring to a sleeve or a bypass. When we have to face to an ineffective sleeve, when we can perform a re-sleeve or transform it in a bypass. And also application can be transformed into a sleeve or a bypass. Everything depends on the causes of the failure. It can be bad dietary habits or of complications like a GERD. Also now more and more teams propose a two-steps surgery. And indeed, when we have to face two very super obese patients, well, it can be difficult and dangerous to propose just one gastric bypass because technically it's difficult. So indeed, also in our experience, we start with a sleeve gastrectomy in order to reduce the BMI until 40. And after that, to finish the work, where we propose then a gastric bypass. I want also to talk about with you where some cases that we encounter in the consultation, and it's not very easy to take a good decision. The The first case is in fact when we have to face to very young women, 18, 80 years old, with a very high BMI and a significant GERD. So in our experience, it's an indication for a gastric bypass, but can we really propose them at this age a gastric bypass before pregnancy? Sometimes they have to grow. So it's not difficult, not easy to respond at these questions. And so for that, all the decision will be taken with a multidisciplinary team, with a nutritionist, with a psychologist, and also with the patient and also with the family of the patient. Another case that sometimes we have to face is super obese patients with all the risk factors that we know: sleep apnea syndrome, diabetes, heart problems. And so it's an indication for, let's say, a bariatric surgery in emergency, like a gastric bypass. But these patients have an active alcoholism. So we know that alcoholism or drug dependency are formal contraindications for surgery. So what to do in these cases? How to treat the patients? How to convince these patients to stop alcohol in order to have an operation? Sometimes it's very difficult. And then the last case is more anecdotal, where sometimes I met patients who request a specific time, a specific type of surgery. I want just a sleeve, or I want just a bypass, because they have friends or family with good results. And it's not always easy to explain them that they have some contraindication and another surgery is sometimes necessary or better in these cases. So I would like to conclude and to insist on respecting the indication and above all the contraindication in our surgical proposal. The multidisciplinary team needs to do a nutritional and a psychological screening to better adapt the approach and the treatment. And as last conclusion, well, the better results will be obtained with a motivated patient and also a very good informed patient. Thank you for your attention.
Thank you very much, Dr. Mark Vertroyen, for your interesting presentation. I have a question, and I think the answer is pretty much obvious. How do you manage a patient with morbid obesity and concomitant lesions in duodenum requiring surveillance? Would you perform sleeve gastrectomy or gastric bypass, or either dividing procedure?
In which cases with a lower bypass with 35, I mean, as a risk factor?
If there is a duodenal lesion, duodenal neoplasm, which requires periodic surveillance like duodenoscopy, would you do here Roux-en-Y gastric bypass or sleeve gastrectomy? It's obvious.
The answer, I think, is very easy. Then we can propose a sleeve gastrectomy. And it is interesting that you ask this kind of question, because we talk about the indication, the contraindication, the pro and the cons, but it's also important to talk about the access on the biliary tract. If there is a gallbladder stone migration, and 1 year ago you did a gastric bypass, well, it's not very easy to reach by endoscopy the biliary tract. So I know that some surgeons will remove the gallbladder, even there is no gallbladder, during the procedure. So what do you think about that? It's difficult to respond. I think we have to inform the patients that there is a risk for that. Also, what's happening with a gastric bypass with the blind stomach? If there is something inside, if there is a suspicion of cancer, how to reach that, to do a biopsy. 2 years ago, I had a patient with cancer with a risk of heredity. And so we screened all the family and his mother had a gastric bypass. Impossible to do in gastroscopy. So we did a PET scan. And indeed, there was something illuminated in the stomach. So what was the good attitude? Okay, to do a screening after several months or to perform a gastrectomy? Difficult to answer. So we did a gastrectomy. Indeed, there was a cancer inside. But yes, it was possible to see there was just an ulceration. So when we do this kind of procedure, we have to give a good information to the patient for the possibilities and the non-possibilities after.
Thank you very much. And one more question. Do you have an experience when patient underwent Roux-en-Y gastric bypass and later on developed choledocholithiasis? How do you manage this kind of patients? I mean, choledocholithiasis. How do you remove stones from the common bile duct?
Well, we ask the help of our gastroenterologist, and sometimes they can reach the biliary tract. Otherwise, it's by surgery. We have to go back and to do an opening of the choledoc and to try to remove the stones. Yes, indeed. But it's very difficult indeed. Yes.
Thank you very much, Dr. Mark Vertroen, for your extremely interesting presentation.
Can I
Yeah, sure.
add some commentary?
Sure, feel free.
We do have some experience with that, since Chile is one of the most prevalent countries in the world with gallbladder cancer. So we have lots of experience in bile duct surgery and gallbladder surgery also. What we take as a common approach in these cases is that we perform a laparoscopy. We access with a 12-millimeter trocar to the gastric remnant, and then through the remnant, we do perform an ERCP. It's almost an ambulatory procedure, and the patients remain admitted for 24 hours at most, and their problem is solved most of the time with no complications, with a very good result.
Mm-hmm.
Very interesting. Thank you very much for.
Yeah,
Dr.
I totally agree.
Brand.
That's what we do.
Thank you, and I would like to invite for our next topic, Dr. Haris Khwaja, and he will be presenting marginal ulcer after laparoscopic Roux-en-Y gastric bypass. Do we have Dr.
Thank you very much, Dr. Samalatza, for that introduction. Can I just check you can see my talk?
We do see, I guess.
Can you see my slides?
No.
We don't really see slides. We just see some files.
Okay.
Oh, we do see right now.
Yes,
excellent.
Okay,
Fine.
Brilliant. Thank you. Sorry about that. Firstly, I'd like to thank Ezisurg for the very kind invitation to take part in this excellent webinar, and also for my colleagues speaking and moderating. Thank you for the opportunity. So my talk is focusing on one of the complications that was alluded to earlier on in this webinar, called marginal ulceration. And specifically, I'm going to address that with respect to Roux-en-Y gastric bypass. So I have no conflicts of interest and no disclosures. This is my surgical case mix since starting bariatric surgery in 2009. And I have a significant experience with laparoscopic Roux-en-Y gastric bypass, which is why I feel comfortable talking about this topic. So marginal ulceration, firstly, we start off with a definition. When we talk about ulceration with respect to gastric bypass, we're really talking most of the time about ulceration at the gastrojejunal anastomosis rather than the jejunojejunal anastomosis. Though you can get ulcers in the JJ anastomosis, due to ischemia or due to a non-steroidal or anti-inflammatory drug use. But for the sake of this talk, I'm going to be focusing on ulceration at the gastrojejunal anastomosis. And typically these ulcers are found on the jejunal side of the anastomosis. I'm going to outline the incidence, the risk factors, the clinical presentation and management of marginal ulceration. In terms of the incidence, if you look at the literature, the incidence does vary between different groups, up to 16%. Some groups do routine post-operative surveillance endoscopy on their gastric bypasses. A lot of us don't do routine surveillance endoscopy unless there's an indication. For example, a patient with symptoms suggestive of marginal ulcer. A lot of these ulcers are asymptomatic. Up to 60% of patients in some studies had an endoscopy not realizing they had a marginal ulcer. Epigastric or left upper quadrant pain is the commonest symptom in up to 70% of patients. And sometimes you can get associated symptoms such as nausea and vomiting, usually if there's associated stricture. But also these ulcers can bleed and cause iron deficiency anemia with all the symptoms and signs that go along with iron deficiency anemia. But what we are really worried about is the ulcer that goes on to cause complications. And these complications include strictures, gastrojejunal strictures, bleeding, which can be catastrophic and fatal if not managed effectively, and also perforation of the marginal ulcer, which also can be a life-threatening complication. Most of these ulcers occur within the first 2 years after the gastric bypass, most of them after 3 months. Now, when we talk about the risk factors, I think Dr. Rashdan spoke about the importance of smoking being a risk factor for marginal ulcers, and that is indeed the case. In our unit, patients who smoke do not get offered any bariatric surgery, because even if you did a sleeve, sometimes a sleeve patient needs to be converted to a Roux-en-Y bypass, say if they get severe reflux. And so having the patient off cigarettes gives you that option to offer them a Roux-en-Y gastric bypass if it's needed. For example, in a patient with an obstruction after a sleeve, for example, or severe reflux after a sleeve. So we're a bit more aggressive in saying smoking equals no bariatric surgery, full stop. NSAID use is a very common over-the-counter medication used in the world, and patients on these medications have a higher risk of getting ulcers at the gastrojejunal anastomosis, and we encourage all patients to be off these drugs prior to having a gastric bypass, as well as steroids. Sometimes, especially the patients with severe asthma on steroids, we try to ask the respiratory doctors to reduce the doses to as low as possible and add in a PPI and get a preoperative endoscopy to exclude peptic ulcer already. And with these steroid patients, I tend to get surveillance endoscopy after their gastric bypass. Excessive alcohol use or excessive intake of acidic beverages is a risk factor for marginal ulcers, as well as Helicobacter pylori. And it's good practice if you do get an H. pylori test prior to surgery to treat it if the patient is H. pylori positive. But it was also mentioned in this webinar that there are technical factors for a lot of these ulcers. They're not purely due to these 4 risk factors, and certainly a foreign body at the anastomosis, be it the staples, the stainless steel staples or titanium staples, or in the early days, some surgeons used to close up the gastrojejunal anastomosis defect after firing the linear staple with a permanent suture. So this is to be discouraged because these permanent sutures can be a source of gastritis and ulceration. An eroded gastric ring, for example, the rings that are used, such as the Phobie ring, can give rise to marginal ulceration as well. Other technical factors include having a large gastric pouch. So if you don't exclude the fundus from your pouch, we know that the parietal cells are mainly localized in the fundus of the stomach. And if you have a very large gastric pouch, including the fundus, then this will increase the amount of acid in that pouch and could lead to increased risk of ulceration. Tension or vascularity of the anastomosis, I think both are important risk factors for ulceration, because a reduced blood supply will predispose to poor healing of the anastomosis. It may not leak, but it may have issues such as marginal ulceration. And we know that patients who have revisional surgery to gastric bypass, for example, specifically from sleeve to bypass, have a higher risk of having problems with marginal ulcers due to effects of the blood supply. And then lastly, gastrogastric fistulas, where you have a connection between the excluded stomach and the gastric pouch, be it due to a leak from the staple line or the anastomosis, or an ulcer that's eroded into the remnant. Or sometimes I've seen 1 or 2 cases where the final firing, when you're creating the pouch, wasn't made effectively, and a little communication was left at the angle of His between the remnant and the stomach pouch, and then that is basically a technical error, which can lead long-term to not only poor weight loss but also marginal ulcers. So there's a whole host of risk factors, be it technical and environmental, patient related risk factors, which give rise to this complicated problem. And this graph here is to show you the effect of smoking on the incidence of marginal ulcer. We do know that we weren't designed to have our stomach pouch or a stomach anastomosed to our small bowel. We were not designed that way. We've done that in the gastric bypass. And we can see here that over a period of time, when you look at 9 years after a gastric bypass, even if you don't smoke, you still have a 12% incidence of marginal ulcer. If you do smoke, that incidence goes up to 18, 19%. But the real worry is those patients who resume smoking, and we don't really know what happens after 20 years. I haven't seen any studies on that, but I've certainly managed a lot of complications due to perforated marginal ulcers in smokers after gastric bypass. And this shows you, this is actually a picture from the Cleveland Clinic, one of my colleagues. And in the early days, these anastomoses were being formed with a permanent suture. And now this is no longer practiced, and most of us either use a Vicryl or a PDS suture to close up the defect in a linear stable gastrojejunal anastomosis. And those doing hand sewn tend to use Vicryl. I do both linear and circular, where you have the circular titanium staples. And so far in my practice with that technique, I haven't had any issues with marginal ulcer. This is a study from, this is a population-based cohort study, and from Sweden, looking at the risk of developing marginal ulcer after gastric bypass in the 5-year period between 2006 and 2011. And all I'd like you to focus on are these hazard ratios, which show an increased risk of marginal ulcer if patients were diabetic, which would make sense because a lot of these patients have got micro and macrovascular disease, which can affect the blood supply to your anastomosis. Patients with a previous ulcer history have a higher risk of getting marginal ulcers, and patients who are taking PPI use, presumably because of history of reflux, can still have a higher incidence of marginal ulcer after gastric bypass. This is another study from the United States, from New York, looking at the impact of marginal ulcer on patients over time. And this really highlights the importance of this problem, because as surgeons, we tend to think, well, after the gastric bypass, they've done great, their diabetes improved, their reflux has improved, their weight has decreased significantly, and we feel very complacent. But the two negatives of gastric bypass that I think that I always emphasize to patients are marginal ulcer and internal hernia. And this study looks at the progression of marginal ulcer after gastric bypass, and it identifies the risk factors whereby those patients who had marginal ulcers needed further surgery. And this was a large study looking at a database of patients having laparoscopic and some having open room-wide gastric bypass in the 5-year period between 2005 and 2010, with a minimum of 4 years follow-up. So this is quite good, much longer follow-up than a lot of us do for a lot of our patients, looking at hazard ratios as a way of identifying risk factors. There were 35,000 patients who underwent room-wide gastric bypass in this study. There was data on marginal ulcer in 6% of these patients. So 6% of all the room-wide gastric bypasses had a marginal ulcer. And of those patients, roughly 9% needed further surgery. So it just shows you the incidence of marginal ulceration overall was 6%. And of that 6%, 10% of those patients needed nearly 10% needed further surgical intervention. And what they concluded in their study, looking at all the variables, patients who were Caucasian, patients who had surgery at a younger age, and patients who had lost a significant amount of weight tended to be the ones which needed further surgery for marginal ulcers, be it emergency or elective surgery. In terms of investigations, the gold standard is upper GI endoscopy. And in our unit, we tend to do preoperative endoscopy on all our sleeve patients. But in the room-wide patients, I only do preoperative endoscopy in patients who've got symptoms of reflux or upper abdominal pain, just to exclude a hiatal hernia, Barrett's esophagus, and also peptic ulcers. But certainly post-operatively, this is the way to diagnose an upper GI endoscopy, and you can see that you'd be able to quantify how much circumference of the anastomosis is involved by the ulcer. By taking photos, you can then compare improvement in the ulcer when you do further endoscopies. So what is the management? Well, it's easy, but it's easier said than done. Advising the patient to stop smoking, reducing the amount of alcohol, and obviously stopping non-steroidal anti-inflammatory drugs would be the kind of simple measures. Reducing acidic beverages as well, and foods. In our hospital, we would recommend proton pump inhibitor, whether you use omeprazole, lansoprazole, or esomeprazole is really very much up to your hospital, but a high dose treatment, oral treatment for at least 3 to 6 months for the management of marginal ulcer in combination with sucralfate, 1 gram 4 times a day for at least 6 months. That's what we do as standard in our unit, in addition to removing risk factors. There are other drugs available. This is a prostaglandin analog, misoprostol, which can be used to help reduce, to help treat marginal ulcers. It's not very widely used, but it is one of the options. H. pylori eradication treatment is something that we would do routinely if we found the patient was H. pylori positive when you did the upper GI endoscopy, or you had fecal H. pylori antigen positive. Now, there's a new drug available, which the gastroenterologists have been using in trials for some time, called vonoprazan. It's a competitive potassium channel blocker, 500 times more effective than omeprazole. I haven't seen any studies of its clinical use in bariatric surgery or in treatment of marginal ulcer, but it may be a drug that over the next 5 years we see being trialed in bariatric surgery patients, but certainly has a very effective profile in terms of reducing acid secretion. Endoscopic management, clearly if there's a foreign material you can see at the anastomosis near the ulcer, using endoscopic scissors, you can cut it and remove that foreign body. If there's a ring that's eroded through, then clearly that will need to be removed either endoscopically or surgery. There are some endoscopic treatments of marginal ulcers which have been done in specialist centers to allow the chronic ulcer which fails to respond to conservative measures by protecting it from the acid environment by suturing mucosa over it and allowing it to heal, have been done. This is a short video, I hope it will play, showing endoscopic treatment of a marginal ulcer. Can you see the video?
Yeah.
So this is the marginal ulcer, quite a large one, occupying nearly 40% of the circumference of the anastomosis, using the Apollo overstitch device. What the endoscopist is basically doing here is covering up the ulcer with healthier mucosa and serosa, almost like plicating over it. And obviously this requires technical training in this device, but if you've been doing this for endoscopic sleeves, then or pouch reduction, then doing it for an ulcer is something very much in your skill mix if you can do it. This was the follow-up endoscopy after 2 months, and you can see that the ulcer is covered up and it's healed, and all the endoscopist does now is to cut the retained suture, the T-tag, and remove it. So again, it's not commonly practiced, but not everyone responds to medical treatment, and not everyone wants a revisional surgery. So this is something that in specialist units, you may want to consider. So in terms of surgical management, which is what most of us would be referred patients for, these are for patients with recurrent or chronic marginal ulceration where conservative and medical management has failed. And also in the acute setting, when we are on duty or not on duty, you may be called about patients with a perforated or bleeding marginal ulcer. And in a more elective basis, patients in your clinic who have developed dysphagia after gastric bypass due to a gastrojejunal stricture. And then you have some patients who have a gastric fistula, which unless that's treated, the ulcer is not going to heal. So what are the surgical options? Well, starting with the simplest one, pouch revision. If you have a very large pouch, the fundus is involved with the pouch, you could revise that pouch to resect make the pouch smaller, resect any large fundus, and see if that will have an effect on healing of the ulcer. A lot of us, including myself, if you have a very large ulcer, chronic ulcer, where the patient's developed a stricture, most of us would tend to revise the gastrojejunal anastomosis, in effect resect the anastomosis and take a segment of the gastric remnant along with it. And obviously if there's a fistula, that would need to be resected. So that's option 2 is what my practice would be, because a lot of these patients have got a severe stricture, and it's just important to realize that unless that stricture is dealt with, it doesn't matter if you revise the pouch or resected it, that stricture still will be there and will be a source of problems with nutrition and dysphagia. Thoracoscopic or transabdominal vagotomy is described in the literature. Again, most of us probably wouldn't consider that as an early option for surgery. In some patients where you have a very short gastric pouch and they're chronic marginal ulcer, you may not have space to redo the gastrojej and may have to resort to doing an esophagojejunostomy. And in some cases, sometimes a patient requests to have their gastric bypass reversed, but obviously that comes with the problems of weight gain and recurrence of diabetes and issues such as reflux, which may have been the reasons for their surgery in the first place. This is a study looking at the surgical outcomes of marginal ulcer management in gastric bypass patients. This is a study from New York, published in SWORD. And what they did is look at patients over an 8-year period who underwent surgery for marginal ulcers after gastric bypass. The median time to reoperation was just over 3.5 years. And in their study, they had 12 patients who needed revisional surgery or redo surgery. And 9 of those patients, interestingly, had gastric fistulas. So that is something when you're looking at patients with a marginal ulcer, even if you think you've done the operation well and the patient did well post-op, you need to really rule out a gastric fistula. So out of these 12 patients, 10 of them underwent a subtotal gastrectomy. And of those 10, 9 had a revision of their gastrojejunal anastomosis. So you can see the majority of these patients are going for a revision of the GJ anastomosis with a removal of the a part of the gastric remnant. I don't think you need to remove the whole remnant, but certainly taking a cuff of the gastric remnant where the ulcer has often got stuck to it, I think is good practice. One patient in the emergency post-operative period had severe ulcer-related bleeding, unusual complication, I would say. To see ulcer-related bleeding in the early post-operative period, had a thoracoscopic truncal vagotomy, and one patient had a total gastrectomy with an esophageal anastomosis. But that patient had previous gastrectomy surgery. So interestingly, in this small study, there were only 12 patients who needed revisional surgery. 3 of them experienced post-operative complications. They included leaks, they included abscesses, but interestingly, 3 years after surgery, there was quite a high incidence there of ongoing problems such as chronic abdominal pain, and also 4 patients had problems with diarrhea. So these are certainly patients that if you've had to go back to revise the gastrojeg or do further surgery, it would make good sense that you offer them regular follow-up, be it clinical as well as endoscopic follow-up, to see whether everything is healing up well and there's no further ulceration. Now, the emergency surgical management is important, and that's why I've included this here, because I get sometimes called when I'm not on call to manage these patients. The basic management would be, situation would be a patient with a perforated ulcer, usually where they would have to be resuscitated, given IV PPI. And generally, if these patients have peritonitis, they should be managed by a laparoscopic exploration, closure of the perforation at the gastrojejunal anastomosis with a suture with an amental patch. Sometimes if it's a very large ulcer, you'd have to revise the gastrojejunal anastomosis as an emergency. That is uncommon. Sometimes you have to kind of do a reversal. Again, that is uncommon. This video here, I just want to share with you. This is a video one of my friends gave me. This was a patient who had a gastric bypass a few years earlier. She never attended follow-up. She kept on smoking. I understand she also used drugs. And she came as an emergency to the hospital with severe peritonitis and severe sepsis. And he was called to manage this patient. And so I'm just going to play the video just to show you. This is a more extreme example of a giant marginal ulcer perforation. And what he found, I haven't shown this, but there was lots of infected fluid, which was around the anastomosis. And after spending a good 10-15 minutes washing out the abdomen, he then proceeds to isolate the anastomosis. You can see that the gastrojejunal anastomosis is stuck to the underlying gastric remnant. And this is what he's trying to separate. All I'm going to do is just forward this a bit so that we can get to the important. So there's lots of scarring at the back of the gastrojejunal anastomosis, and you can see the ulceration just at 3 o'clock. And what he's done is he's just taken down the gastrojejunal anastomosis by cutting across the stomach, and you can see the mucosa of the stomach there, where the perforation right there. And it's a difficult situation, this, because the patient is very sick. And what he decided to do in this case is he decided to free up the gastric pouch, reduce the amount of tension on the anastomosis, and he went on to create a new gastrojejunal anastomosis. So a lot of us, when we have these cases, they tend to be kind of pinhole or small perforations, but this case was clearly a very large ulcer. And what was done here was to basically reanastomose the gastric pouch with the roux limb again. Now, a lot of us wouldn't have done this. Perhaps some of us would have converted this to open. Perhaps some of us would have come back after 24, 48 hours after stapling off the gastric pouch and leaving an NG tube in to do an anastomosis. But he decided to do all this in the acute setting, and the patient did very well. So the beauty of the stomach, unlike the colon, it does have a very good blood supply, and it shows that if you deal with vascularity and tension issues, you can still have a good outcome even in the acute setting. So he's done a linear staple gastrojeg, and then he just closes up the defect in 2 layers, leaves a drain in, MPO, and observed the patient, and the patient did very well. And then he put an ammental patch on top of that. Something that I would do routinely, even for the smallest ulcer. So gastric fistula, just a small note of this. When you look at the data, 19% of patients with marginal ulcers have an associated fistula. If the patient's asymptomatic and has no actual marginal ulcers picked up incidentally, you could observe it if it's not causing any actual problems. But most of the time, it's picked up in the setting of a marginal ulcer, and surgery is generally indicated. My understanding of the role of endoscopic treatments of gastric fistulas using the Apollo overstitch are that the results aren't as good as perhaps they were thought to be initially. So I would say that for a gastric fistula in a patient with a chronic marginal ulcer, surgery would be indicated to revise the anastomosis and resect the fistula. And this is just an example here of a fistula, very nicely demonstrated, presumably due to breakdown of the staple line, or in some cases, the anastomosis giving rise to a chronic inflammatory process. So in summary, marginal ulcers are a common long-term complications. The reason why a lot of us don't think about it is that we don't always routinely survey our patients endoscopically. But if you look at the literature, it is a common problem, especially if patients are lost to follow-up and don't adhere to the rules in terms of appropriate diet and avoiding certain medications and habits. It is important to recognize the problem early by asking for an upper GI endoscopy and identifying risk factors, and also treating those risk factors. It's important to institute aggressive medical management and also follow-up endoscopy so that you can check that this ulcer has healed. That is very important. Surgery is really for patients with failed medical treatment or with acute surgical complications. And I would advise you do not ignore this problem, because sometimes it can come back to you. So that patient who comes to you complaining of epigastric pain 2-3 years after gastric bypass, take everything they say seriously. And there's no harm in doing an upper GI endoscopy to rule out a marginal ulcer. Thank you.
Thank you very much, Dr. Khwaja, for your interesting presentation about a very important topic. I would like to ask you, as you have mentioned, it's very important to separate fundus from the gastric pouch in order to avoid excessive functioning of parietal cells and production of the juice, which may lead to the increased risks of development of marginal ulcers. And another risk factor you have mentioned is a large gastric pouch. Is there a threshold, like volume-wise, where there is a significantly increased risks of marginal ulcers?
Yeah, I mean,
which should consider when performing this type of surgery?
I think that's a great question. I'll tell you, initially 10 years ago, I did my fellowship in 2009 at the Cleveland Clinic, and we did very short gastric pouches. It was literally below the first branch of the left gastric. It was one firing across and 1 or 2 vertical firings, and then doing a linear staple anastomosis. But I still saw marginal ulcers. And now my practice is to do long, narrow pouches. And I just think you have to weigh up having, obviously excluding the fundus is critically important. I think that's Absolutely. You can't have your fundus in your pouch, because we know from basic physiology and anatomy that those cells are localized mainly in the fundus. But I think it's a balance between having excluding the gastric fundus, having a reduced gastric volume, but also tension on the anastomosis. So I tend to do a little longer pouch, and I do follow up on my patients. And I must say, I haven't seen a high incidence of marginal ulcers in the first 6 to 12 months. The patients that I have seen ulcers are several years later who have restarted smoking or heavy drinking, or they're using ibuprofen, NSAIDs without realizing. So in terms of saying a specific volume, I think it's just important to exclude the stomach and the gastric fundus, and also being very meticulous in your follow-up. Because if you have even patients with a longer pouch, in my practice, I haven't seen any increase or any significant cases of marginal ulcer. So, but what I do feel is, like what Dr. Rashdan mentioned earlier, I do think that marginal ulcer may also have a significant technical component. So if you have a short pouch, but your roux limb is stretched and it's under tension, I do worry about the blood supply, because if you look at the mini gastric bypass surgeons who do have a much longer gastric pouch, 25 centimeters, yes, there are cases of marginal ulcer, but it's not an epidemic of marginal ulcer. And my pouch is not that long in Roux-en-Y, but certainly I think it's to do with a combination of a good blood supply, reduced tension, excluding the fundus, and obviously we're using the right technique to do the anastomosis, including the right suture material. So I don't think giving you a volume as to what would mean that you won't have marginal ulcers would be an accurate thing to do.
Thank you very much for your very thorough explanations. And I would like to summarize our meeting. I would like to talk about a few important things. So what we have already discussed, we have discussed comparative outcomes of laparoscopic sleeve gastrectomy and laparoscopic Roux-en-Y gastric bypass surgeries. Each procedure has its pros and cons, its risks and benefits. And it's obvious that multidisciplinary team, along with patient and patients, relatives and parents, should be involved in the decision-making process when choosing a proper and more suitable procedure for the particular patient. So such factors as diabetes, anemias, BMI, esophagitis, reflux, vitamin deficiencies also, I think, also should be taken in consideration. And patient should be informed about possible risks and perioperative complications for each particular procedure. So Professor Khwaja has presented and explained in very detailed factors which might be considered during surgery and as well as following surgery in order to diminish risks of marginal ulcers development, and if they develop, how to manage them. So like stepwise approach, first we treat medically. If we don't get any desirable outcomes, we go for endoscopy, and then finally with surgery and revisionist surgery. So I think, to put it in a nutshell, both procedures are effective in the treatment of obesity and obesity-related comorbidities. Now, I want to finalize our meeting for today. It was my pleasure to serve as a moderator for such an interesting webinar, and I want to express again my thankfulness to Ezisurg Medical and to our speakers.
Thank you very much.
Thank you.
Thank you very much.
Thank you.
Thanks so much. Thank you.
Thank you.